Hello and welcome to Learning EMG. In this video series, we're going to review the clinical and electrodiagnostic features of the most common neuromuscular disorders. If you find our channel informative and helpful, please do subscribe and do not forget to hit the bell icon to be the first who watches our videos. In this video, we're going to review Amyotrophic Lateral Sclerosis or ALS. Let's dive in. Amyotrophic lateral sclerosis, or ALS, is a neurodegenerative disease of the motor neurons that affects both the upper motor neurons and the lower motor neurons. The evidence of upper motor and lower motor neuron involvement can be found in four regions: the bulbar region, the cervical region, the thoracic region, and the lumbar region. We will discuss the criteria for diagnosis of the ALS in the next sessions. The typical clinical presentation of ALS is that of a painless muscle weakness and progressive motor deterioration, manifesting with both upper motor neuron and lower motor neuron signs and symptoms. Lower motor neuron involvement manifests with muscle atrophy, fasciculations, and diminished reflexes. On the other side, the upper motor neuron findings include muscle stiffness, spasticity, brisk reflexes, and positive Babinski response. Muscle weakness most frequently starts in the limbs muscles and more often in distal muscles than the proximal muscles. This presentation is usually known as limb onset ALS or spinal ALS. Onset of symptoms is more common in the upper than the lower limbs. In some cases, weakness begins in the bulbar muscles and manifests with dysarthria, dysphagia, dysphonia, or facial muscle weakness. This presentation of ALS is known as bulbar onset ALS. Axial muscle weakness with head drum and problems with the posture are common in the advanced and late stages of the disease, but these features rarely can be found as the presenting symptoms. Muscle twitches and fasciculations may be found in the arms, in the legs, in the shoulder, or in the tongue. An important point to consider when examining patients suspected of having ALS is that sensory symptoms such as numbness or paresthesia or sensory loss are characteristically absent in patients with ALS. So, sensory examination is normal in patients with ALS. Marked autonomic dysfunction, ophthalmoplegia, abnormal sphincter control, and extrapyramidal symptoms are extremely rare in ALS. Such findings should prompt an investigation for an alternative diagnosis. The disease process may be more aggressive in patients with bulbar onset ALS and older ages at onset. Now, we're going to review the diagnostic criteria for ALS. It is important to note that in the recent years, several diagnostic criteria for ALS have been proposed. However, the latest diagnostic criteria for ALS was revised in 2015 by the International ALS MND Consortium. These criteria are referred to as the revised electoral criteria with Abaji modification. This criteria is as follows. The first category of the ALS based on the revised electoral criteria is clinically definite ALS. This category requires evidence of lower and upper motor neuron involvement in at least 3 spinal segments or 2 body regions. The second category is clinical probable ALS. The clinically probable ALS requires evidence of lower and upper motor neuron involvement in at least 2 spinal segments or 2 body regions. The third category is clinically possible ALS. This category requires evidence of lower or upper motor neuron involvement in only 1 region. And finally, the last category is called clinically suspected ALS. This category requires symptoms suggestive of upper or lower motor neuron dysfunction, but additional evidence is needed to meet the criteria for one of those other categories. Overall, the diagnosis of ALS is sometimes challenging because ALS can resemble other conditions, and there is no definite test for ALS. Therefore, an examiner should consider both the clinical features, the electrodiagnostic findings, and other tests to reach the definite diagnosis of ALS. An important point to note is that a major change with the AWG modification is that the EMG evidence of lower motor neuron involvement is now considered equivalent to the clinical features of lower motor neuron involvement in an individual muscle. In addition, the fasciculation potentials are now considered evidence of acute degeneration in the setting of already established chronic degeneration. The application of the AWG modification increases the diagnostic sensitivity of the revised L-scale criteria for ALS diagnosis. The clinical and electrodiagnostic criteria for ALS are summarized in tables 5-1 and 5-2 of the book. Okay, now we're going to review the electrodiagnostic characteristics of ALS. First, we're going to review the sensory nerve conduction studies, and we'll begin with SNAPs. As you know, and as I have already mentioned, ALS does not involve the sensory system. Because the sensory system is spared in ALS, sensory nerve conduction studies are always normal in patients with ALS. Abnormal nerve conduction studies should prompt reassessment of the diagnosis and further evaluations to rule out other causes. With respect to motor nerve conduction studies, motor responses, the CMAPs, may remain normal until there is sufficient oximal loss to result in diminished or absent CMAP amplitudes. With respect to the latencies and NCVs, you should note that there may be a slight prolonged latencies and mildly decreased NCVs, but the electrophysiologic criteria for primary demyelination are not met in patients with ALS. Please note that the absence of demyelinating features and conduction block are critical for diagnosis of ALS because, as you know, some other demyelinating motor neuropathies, for example, multifocal motor neuropathy, can have similar clinical manifestation to ALS. However, multifocal motor neuropathy is usually associated with conduction blocks and other signs of demyelinating features on NCV or nerve conduction studies. Finally, we're going to review the needle EMG findings in patients with ALS. Based on the AWG modifications, abnormalities on needle EMG in any given body region can have equal diagnostic significance to the clinical evidence of lower motor neuron disease. Needle EMG is particularly helpful to identify subtle evidence of lower motor neuron involvement in areas where they are not clinically evident. Muscles determined to be affected on EMG must show both the acute degeneration and the chronic neurogenic changes. The acute degeneration potentials are positive sharp waves, fibrillation potentials, and fasciculation potentials. And the signs of chronic neurogenic changes are MUAPs with long duration, high amplitude, and polyphasia. Unstable MUAPs on triggered analysis are also considered evidence of chronic degeneration and immature synapse formation. Once again, please note that the AWG modification included fasciculation potentials as evidence of acute degeneration in the tested muscles. The examiner should note that during the needle EMG examination of patients suspected of having ALS, at least 3 limbs should be studied. In addition, at least one bulbar muscle, such as facial muscles, the masseter muscle, or thumb, should be examined. 2 muscles of different root or peripheral nerve supply must be involved to be considered as evidence of lower motor neuron involvement in any given region, for example, in bulbar or cervical or thoracic or the lumbar region. Finally, you should note that EMG examination should be performed on at least 2 thoracic paraspinal muscles to check the thoracic region. In recent years, other electrodiagnostic techniques have been introduced for identifying ALS patients in early stages. We will review these tests. With respect to repetitive nerve stimulation or RNS, you should note that the low-rate RNS, RNS with 3 Hz, in patients with ALS shows abnormal decremental response in nearly half of the cases. Recently, the research is going on motor evoked potentials in ALS patients. The transcranial magnetic stimulation induced motor evoked potentials, or MEP, is suggested as a reliable method in identifying subclinical upper motor neural involvement in cases suspected of having ALS. Abnormal findings in MEP include increased central motor conduction time, absent MEPs, or features of cortical hyperexcitability. Finally, with respect to single fiber EMG. Single fiber EMG usually shows increased jitter and blocking, reflecting the neuromuscular junction transmission failure. Increased fiber density, which is a sign of denervation and reinnervation by collateral sprouting, is also seen. Okay, now in this video, we review the clinical and electrodiagnostic findings of ALS. We've gathered a summary of clinical and electrodiagnostic features of the most common neuromuscular disorders in this pocketbook entitled Summary of Electrodiagnostic Medicine. This book is available on Amazon website. You can hit the link below in the description to see the book page on Amazon website. Hope to see you soon with another summary video. Take care and goodbye.